Good morning. Thank you for being here so bright and early today. My name is Will Andrews. I have teaching affiliations at my alma mater, UCSF, as well as West Virginia University, University of North Carolina, and MedStar Health in Washington, D.C. But really, I spend the majority of my time in private practice in San Diego, California. The title of my lecture is Incisor Positions that Complement Health, Function, and Appearance. And I don't have any financial or commercial incentives related to the content of this lecture to declare. The inspiration for this lecture comes from the realization that we orthodontists are still confronted with some very fundamental, basic questions to answer, such as where do the teeth belong within the jaws, and does it matter? And where do the jaws belong? And are we measuring things the right way? And if so, how do we move the teeth and jaws to the intended positions? And what positions ultimately will best serve the needs of the patient in terms of health, function, and appearance. My lecture is going to be focused just on the incisors. And incisor positions, if they're correct or incorrect, will impact oral health, dental health, quality of the occlusion, and smile appearance, or health, function, and appearance. I'm going to focus just on two things. Number one would be the inclinations of the crowns of the incisors, measured as the relationship between the FACC and the occlusal plane. And number two, the root positions, anterior-posteriorly within alveolar bone. And I'll start with crown inclinations. Now we have excellent data from a well-known study, a sample collected by my father, Lawrence F. Andrews. There's a sample of 120 naturally occurring optimal occlusions that's well known. He studied those tooth positions, and ultimately that resulted in the 6 Giesed optimal occlusion, and later the development of the straight wire appliance. But the actual measurements, the data that came from those measurements, is published in his textbook, Straight Wire, the Concept and Appliance, which was published in 1989. And in that book, there's the data, as you see here, regarding inclination of the incisors, the average inclinations. Maxillary incisors are only 6 degrees. It's not very much. And mandibular are negative 1.7. And those values were kind of rounded off to +7 and -1. And there's nothing necessarily magic about that. It's just an average value. But when you deviate from those ideal inclinations, significantly deviate, it can influence what's called the perimeter lines, which are this illustration there of the black line that connects cusp tips and incisal edges of the teeth in an arch. When you have excessive inclination of an incisor, it elongates the perimeter line or creates more overjet than is necessary. And when you have insufficient inclination, it creates a short perimeter line or less overjet. Same with the mandibular arch. For example, a short maxillary perimeter line, if you have insufficient inclination, eliminates the necessary overjet that would be needed to correct posterior interarch relationship. So you kind of run out of overjet before you can correct interarch relations. The correlation between perimeter lines and posterior interarch relationship has been studied by the same authors in a few different papers, Sang Char Arm, if I'm pronouncing it correctly, and Ho in 2007. Regarding maxillary incisor inclination, they concluded that inclinations that deviate significantly from normal values are likely to result in less than ideal buccal segment relationships. a long mandibular perimeter line, which is something we probably encounter very often in orthodontics as a side effect of correcting class 2 malocclusions, have an almost identical effect where you're taking away overjet before you can correct posterior interarch relationships. And perhaps we've all seen or experienced clinical cases where we've inadvertently proclined lower incisors, and despite there being no overjet, we still don't have the posterior segments corrected. And these same authors that I mentioned before on typodont studies also concluded that excessive proclination of lower incisors do result in abnormal overjet and prevents the attainment of correct occlusion. A long maxillary perimeter line or excessive positive inclination would seemingly help, at least in terms of creating surplus overjet to help correct interarch relations if it's a class 2 problem. And so a lot of orthodontists lean towards having a lot of torque or inclination on the upper incisors, but it has its own set of problems when you have too much inclination. One of which is a lack of vertical overbite and increase in overjet, but that increase in overjet can be useful. But the decrease in vertical overbite can interfere or prevent protrusive guidance. You have lack of good protrusive guidance and function. In addition, from just an aesthetic point of view, the smile arc, which I won't talk too much about, but when the maxillary incisors are excessively positive, it creates a flattened or sometimes, as in this case, a reversed kind of a smile arc. So aesthetically, from the frontal perspective, not good to have too much inclination. In profile, there's also an issue with inclination of incisors, profile aesthetics. The teeth really are part of the face, and we like to evaluate the positions of the incisors in profile with the patient smiling for a couple reasons. One, to look at inclination. This is a study published in 2011 where they morphed the inclination of the maxillary incisors from negative to slightly positive to very positive, and judges were asked to rate the attractiveness. And this article concluded that upright or very vertical or even lingual or negative inclination was preferred, and that labial or excess positive was always rated lowest in by all the judges. There are a few other similar studies like this, but they all conclude something similar, that very positive inclination always rates the lowest aesthetically. Such as this article from 2015 in the AJO-DO, where they morphed the incisor in lots of different inclinations, and their findings were that this was the preferred range. Anything from -5 relative to an external frontal plane to 0 or upright, or to slightly positive, +5. And another article from the European Journal in 2011 concluded that +5 was the most preferred. And this one, very recently, just a couple months ago, in the AJO-DO, concluded that -5 was the most preferred in this study. So how does that comport with the +7 inclination that's deemed favorable for interarch correction? Well, if you have +7, that, remember, is measured relative to the occlusal plane, FACC relative to the occlusal plane. And most individuals don't have an occlusal plane that is parallel to the floor. It's usually sloped downward gently from posterior to anterior. In this case, for example, it might be +2 degrees relative to a true transverse. And if so, then that 7-degree incisor will appear externally as +5 relative to an external pure vertical. So if you have +7, which is a good starting point anyway for diagnosing, and you tilt those casts as steep as you want to make the occlusal plane, you still would want that +7 for interarch correction. But of course, those incisors would appear negatively inclined when the patient smiles, and that's just because of the steep occlusal plane. There's one further study on the topic that is unpublished. It's a master's thesis from Virginia Commonwealth University, and I wasn't involved in it at all. I just found it online. But this study concluded, they did a similar type survey and found negative 8 degrees was most preferred. They concluded in this article that the majority of evaluators, and this crossed racial and gender, preferred retroclined. Negatively inclined was always picked as most preferred, which is interesting. So a patient like this, who I treated, maxillary incisor ended up well related to the occlusal plane, and the occlusion is good. But the patient happens to have a very steep occlusal plane, 14 degrees. A good range would be +2 to +10 in that range, would be compatible with smile aesthetics. But she has a very steep one. So that +7 degrees relative to the occlusal plane is going to appear -7 in the face when she smiles, like this. And based on the studies I've shown you, that happens to be perfectly acceptable according to laypersons and orthodontists that judge in these published articles. So it's not unacceptable to have negatively inclined incisors in profile. In summary, maxillary incisor inclinations that are slightly negative to up to slightly positive relative to an external frontal plane have been associated with the highest ratings for smile attractiveness in profile. Excessively positively inclined maxillary incisors are comparatively unattractive. So the ingredients to what we all are trying to achieve for our patients, health, function, and appearance, is to have incisors well related to the occlusal plane, coupled with an occlusal plane that's not too steep or too flat. And if so, then those incisors will appear, externally anyway, very upright or possibly slightly negative or slightly positive. And those incisor inclinations will be compatible with correcting interarch relationship and a good smile arc, assuming that the occlusal plane is positively inclined. If you think about all the things that just inclination of incisors can influence, that I've talked about, smile arc, profile smile aesthetics, protrusive guidance due to lack of vertical overbite, and posterior interarch relationships, and you map out all the different possibilities or combinations of positives and negatives, that the only scenario in which you check all the boxes is when you have these green or slightly positively inclined maxillary incisors and slightly negatively inclined mandibular. And the groups that rate the lowest in all categories are on the top row. What they have in common is they all have excessively positively inclined maxillary incisors. So that one feature always puts you at the bottom of the list. So from a treatment point of view, you might consider not putting too much torque on maxillary incisors for all those stated reasons, or at least if you do have that built into your prescription, not to fill the slot entirely. Now let's talk about AP root positions. Are there limits? If you have ideal inclinations, you can still move the teeth back and forth within the alveolar bone. So are there limits? This article from Garib et al. From Dental Press in Brazil concluded that, or hypothesized that alveolar bone itself was the limiting factor for orthodontic tooth movement, beyond which dehiscences or fenestrations or attachment loss will occur. And now, these days with CBCT imaging, we have the chance to visualize more than before what we might actually be doing with root positions relative to supporting tissues. This is a patient that was treated at the clinics at UC San Francisco. Slides loaned to me from Jerry Nelson, who gave a lecture on root position. And the patient had a fixed class 2 corrector, and it went uncontrolled or unmonitored, and these have the potential, if used incorrectly, to move teeth right out of the alveolar housing. In addition, if you retract teeth too far within the alveolar bone, in an extraction case or distalization of a whole arch, you also run that potential. This article from the Angle orthodontist in 2020 looked at the response of the bone, alveolar bone height, relative to proclining mandibular incisors in class 2 treatment. And they found that changes in lower incisor inclination relative to NB and or incisor mandibular plane angle appeared to be correlated with vertical bone loss and dehiscence, and that the limits of incisor proclination or protraction are less than previously thought. So we don't have a lot of safe working room, especially when the alveolar bone is very narrow. And this article, also very recently published in the Angle orthodontist, looked at retraction of maxillary incisors, maximum retraction with microimplants and the effect on alveolar bone height. And they concluded or found remarkable changes in the height and thickness of alveolar bone after microimplant aided incisor retraction in all groups. But something else that's interesting to consider that I hadn't given a whole lot of thought to before is the role of the incisive canal in the maxilla. And I first read about this in this article in 2015 by Judy Chung and others. It's just a case report of 2 patients, but they hypothesized that contact of the maxillary incisor roots with the incisive canal, which is surrounded by cortical bone, might lead to the potential for root resorption. So they looked at 2 patients after maximum retraction with using TADS and found that there was encroachment of the roots on the incisive canal and root resorption. Now, you can't really necessarily draw cause and effect from a case report, but it's just a correlation that they saw. And a few years later, another group from Korea and Japan published this article in the Korean Journal of Orthodontics, just a single case report of maximum retraction of incisors in both arches to reduce protrusive profile, reduce a gummy smile. Very beautifully illustrated article showing the incisive canal in yellow and the contact of the roots of the incisors after retraction with the canal. And they documented encroachment of the roots into that canal and the associated root resorption. And this is the first article that I'm aware of that actually did a real study of 33 patients and compared the amount of root resorption observed in individuals that contact between the roots and the incisive canal was documented versus those where it didn't contact. And they concluded that contact caused significantly more apical root resorption than those that didn't contact. And this very, very recently, in the AJODO, looked at the response of the canal to root contact. And they concluded that the amount of root resorption indicated a tendency to increase in the order of separation, approximation, contact, and invasion of the root to the incisive canal, and that contact or invasion of the maxillary incisor roots was fairly high after maximum retraction. So what guidelines do we have? Where should we be thinking when we're moving teeth? Well, this is what we tried to look at in this study. We used a sample of naturally occurring optimal occlusions, the same sample that my father collected, which grew eventually to 220 sets of plaster casts. But some of them actually had lateral head films, not all of them. And they'd never really been studied. So we used those and published this article in this year, January of this year, in the Angle orthodontist. From that sample of 220, we found 57 usable lateral head films that were good quality and traced them. And for comparison, we gathered a group of 57 also untreated but skeletal class 2 malocclusions, just as a basis to see if there was any sort of difference in root position based on malocclusion. There were 57 in both samples. The ages were slightly older in the optimal occlusion sample, but both in the young adult range. Similar numbers of males and females in both samples. And these are the measurements we did, mostly just to where the roots were relative to bone, how thick the bone was, and the inclination of the incisors. And the data, the conclusions were that first, regarding skeletal relationships, this just shows, using the Witts appraisal anyway, that they were skeletally different, that there was a significant difference in AP jaw position, at least according to Witts. So we were dealing with two different anatomic groups. The total thickness of the alveolar bone between the two samples was similar. In the maxilla, for example, it was 10.3 total thickness versus 9.82 in the class 2 sample, which was significant, but only 0.5 millimeters total difference. So clinically, probably not very significant, but statistically so. In the mandibular arch, they were 10.5 versus 11, and that was not statistically different. So anatomically, again, fairly similar groups. And what we really were looking at is, within the alveolar bone, where was the root to be found? And it was really, this slide, probably the most distinct finding. And that is that maxillary incisor roots in both samples were in the anterior 1/3, almost, always. And by a 2-to-1 ratio, about 3 to 6, basically 3.5 millimeters to 6 millimeters, if measured from the center of the root. They were always kind of parked in the ocean view hotel room, not the garden view. So they like it out there, and you'll see when you look at your own patients, you almost never see it otherwise, at least if you measure from the center of rotation. So it's 2-to-1, and so distinctly different were those two values within each group, where there was never one example where the root was in the middle or posterior to the middle, always in the anterior, never in the posterior region. And mandibular incisors were essentially centered if measured at the apex, and that's the only place we did measure. So in the optimal occlusion sample, it was 1-to-1, no significant difference of those two values on either side of the apex. In the class 2 sample, the apex was more posterior within bone, indicating perhaps dental compensation for the overjet. And inclination of the incisor, surprisingly, wasn't different between the two samples. There was a much larger standard deviation in the class 2 sample, but on average, they were inclined just about the same, not statistically different. Whereas in the lower arch, there was more proclination of the lower, again indicating likely just natural dental compensation for the skeletal problem. So this summarizes the findings between the two samples. 2-to-1 ratio in terms of bone surrounding the roots in the upper arch, and in the lower 1-to-1. In the class 2 sample, roots, apices slightly more posterior and slightly more inclination of the crown. In comparison to other studies on this particular topic, there are a few others, but nobody had studied naturally optimal occlusions, just untreated. In this study, they looked at different face types, short face versus long face, finding that the alveolar thickness was thicker in short face and thinner in long faces, but that the roots were generally parked in the anterior. In other words, maxillary root, they measured at the apex, was further from the lingual cortex in short faces than in long faces. And that really can be interpreted, at least my interpretation is that this implies that despite the increased thickness of bone, alveolar bone, in those with shorter faces, the incisors still were in the anterior third, or closer to the anterior. In this study, there was a sample of 90 untreated individuals divided into 3 groups, but when they put all 3 together, 3 groups of 30. But altogether, if you look at their data, this is their data published in the article, it's about 2-to-1 ratio also, if measured at the center of the root. And if you can imagine, you can kind of see it in the ossified area there where the incisive canal would be. that if you imagine that being there, that the roots are actually quite centered in the available bone. So there's a reason why nature seems to put them there, most likely. They're centered just like the mandibular is, it's just that there's an incisive canal to deal with. So the baseline is for diagnosis and treatment planning is to start with these positions in mind. If so, you can be reasonably assured of health, function, and good appearance. Now, there's another part of external facial appearance or harmony to consider, and that is the AP position of the incisors. Not the inclination, but the AP location in space. There's a line called the goal anterior limit line, or GAL, that is a frontal plane passing through glabella or near glabella that can be used to assess in space the AP position of the incisors. There's a pretty lengthy body of evidence now that has looked at this relationship of incisors to gall, and most of them have concluded that it's a reliable and effective landmark to use for this particular part of diagnosis and assessing facial harmony. Dr. Marco Estrada treated this patient. He's in the audience here. Thank you, Marco. This is just an example of a patient where we have the gall line established as a goal, and her maxillary incisors are clearly posterior to that, and mandible is anterior. So she needed surgery ultimately to advance the maxilla and retract the mandible, the gall line being the target. And the outcome was excellent, thanks to Dr. Estrada and his brother, the surgeon. In my own practice, I did a basic kind of survey of 100 of my own patients, just randomly selected, to see, based on that gall line, where the maxilla was in space. Red indicates too far forward, green indicates just right, and black too far back. So 63% of my patients, the maxilla was too far back, and only 22% you could say are pretty good to start with, and only 15% too far forward. So 85% of them, in my practice anyway, you wouldn't really want to retract the incisors bodily within the alveolar bone, because these jaw measurements are made with the assumption that the incisor is already in the right spot in the bone. And so if the jaw is in the correct position or posterior, you wouldn't want to retract the incisors anyway. So we're only talking about retracting incisors now within the maxilla in about 15% of patients. And again, in my practice, these 15% that had a maxilla that was prognathic or protrusive, if you could say, they were only protrusive by mostly 1 millimeter, maybe 2. So in terms of compensating for that dentally, the amount of retraction needed for maxillary incisors is pretty minimal, where you might want to use torque or something like that, at least in my patient pool. This is an example of a patient that had maxillary incisors retracted with torque control and premolar extractions, and you can see where the root is relative to alveolar bone, and that you don't see in nature. Nature doesn't do that. If you ever see a root in that position, you know that they had treatment. I've never once seen that in an untreated person. So that's a root, man-made root position. And if his maxilla in profile was green or in a good position, and this was done simply to correct overjet or correct class 2, his maxillary incisors were moved away from where they maybe aesthetically might have been better, back in the front of the jaw. So one of the big problems we still have in orthodontics is the way we measure these things. We're using some traditional cephalometric measures that aren't necessarily so reliable. We want to know, I don't want to know all this, I don't use any of it. I want to know, how does the FACC relate to the occlusal plane? That's where the rubber hits the road in terms of occlusion. How do the incisor roots relate to the surrounding bone? And how do the jaws relate to the forehead? That's what I want to know. So the solution, or at least part of the solution, is to not use those measurements, but to use another way of measuring. We use a template like this that has incisors cut out at the proper or ideal inclinations. You have a patient, take an x-ray, and before you diagnose, you make a clinical assessment about the relationship of the incisors, maxillary incisors, to the gall line. Hers are behind. Take her lateral head film, superimpose the template so that the occlusal plane of the template is on the occlusal plane of the patient, and then you slide it around till the root is in the anterior 1/3, or where you decide the root ought to be, and trace it there, like a visual VTO. Trace it so that the middle of the root is in the anterior 1/3, 2-to-1 ratio. And same for the mandibular. In this case, you would center the apex of the template tooth, and the template is going to automatically correct the inclination to the occlusal plane. That's how we measure it, to ensure that we're getting the teeth in positions that will complement occlusion, health, and function and appearance. And then you can draw this gall line and see how everything relates to the face externally and decide how you're going to deal with that. If the incisors are in optimal positions within the jaw, then technically that's a jaw problem from here on out to get the incisors where you want them. It might involve growth modification or surgery. If the patient doesn't want that, or you're not capable of it because of age, then you're talking about compromising incisor positions. You're either going to have to move the roots out of the preferred area or incline the teeth in ways that might affect perimeter lines. And you'll have to pick your poison. But either way, it's going to be a compromise. Here's another patient with an anterior open bite and kind of a class 2-ish malocclusion. Her maxillary incisors are slightly ahead of the gall line before treatment is initiated. Here's the lateral head film. Before we even draw the gall line on there, you just don't worry about that and reposition the incisors in ways that will be healthy and functional. Root in the anterior 1/3 for the maxillary, and root apex centered in the lower. And that's kind of what you're looking for, and the template will do that automatically. It doesn't matter how they relate to mandibular plane or palatal plane or SN or any of that. What matters is how they relate to the occlusal plane and if the roots are in healthy positions. When it comes to treatment, to move the teeth from where they start to where you want them, one of the most interesting clinical things is that it doesn't require torque, and that's probably a 90% rule, that to get them into the proper inclination is pure tipping. The roots are already, nature kind of already gives you that to start with, and they've only, changed position through natural tipping, and your job is just to tip them back to proper inclination. So round wire will do it. You don't need torque most of the time. And once you achieve that, then you can look at facial aesthetics, where the gall line is, and if the maxillary incisor is already on the gall line after moving it to this ideal position, then that jaw technically is correct already in the AP dimension. So whatever overjet remains is all due to the mandible. So this is an adult. She needed surgery. She agreed to have the mandibular advancement surgery. So clinically, you do whatever you have to do to get the incisors into those green positions. In this case, it required extractions. And extraction sites are closed in a controlled way so that the incisors are not over-retracted, but it's all done on round wire. And once you get the incisors to tip to where you want them and you've eliminated whatever crowding may have existed, and progress or pre-surgical records are shown here. You can check on the lateral head film to see if you've moved the incisors as you hoped or intended, that they've tipped, and the roots are where you want them to be, and that the maxillary incisor is on the gall line, and then patient's ready for surgery. Well, she had mandibular advancement. And the outcome is good, and you can see that she has a good occlusion. The incisors are 7 degrees to the occlusal plane, but she has a 7 degrees of inclination of the occlusal plane. So the presentation of the crown to the world is going to be perfectly upright, straight up and down. But based on those studies I showed you earlier, that's perfectly in the realm of acceptability and actually preferred based on the evidence. So in conclusion, as I've shown you, incisor positions influence oral health in terms of the supporting tissues, dental health in terms of root resorption, quality of the occlusion in terms of their effect on the perimeter lines, and smile appearance, both from the frontal and profile or lateral perspectives, health, function, and appearance. And the final take-home messages, the list here, is to avoid excess positive or negative incisor inclinations. It's detrimental to occlusion and to aesthetics. Use low torque bracket prescription for maxillary incisors as opposed to error on the low side, or at least don't fill the slot if you're using a high torque. Oops, sorry. And maxillary incisor roots ultimately should occupy the anterior 1/3 of the alveolar bone. Mandibular incisor apices centered. Tipping, labiolingual tipping of incisors is the appropriate method for reaching the intended goals. No torque or limited torque. And probably should avoid very much bodily retraction of incisors for most patients. In my practice, that means 85% of them. Well, thank you very much. Appreciate your attending.